So we're just going to have, take it away, John.
Okay, thank you very much for having me here. Before I begin, I'd just like to acknowledge that I don't think it's enough just to acknowledge that we are gathered here on Treaty 6 and Treaty 7 territories, but also
and the Métis home.
And the home of the Métis Nation. But also to acknowledge that Indigenous peoples have been the custodians of Turtle Island since the dawn of time. I also do want to add and in response to the Truth and Reconciliation's call to actions on healthcare, I do also want to acknowledge that the current state of healthcare in our First Nations, Métis, and Inuit peoples is a direct result of previous government policies, including the residential schools. Now, one thing I will admit is, as several people in the audience know, I've gone across the country giving dozens of these presentations and engaging with different First Nations and non-First Nations communities regarding dried blood spots. But as I was preparing for today in the presentation, I was really nervous and I was trying to figure out why. And I think it was when I received the agenda from Carrie Lynn where it kind of struck me that I think we really are on the beginning of history. This is a historical moment that is happening, especially with the Métis Nation. And I think this would also help to explain, what was this salty, watery discharge that was starting to cool in my eyes as I was preparing for this. But there's no, I'm stating the obvious, the last 2 years especially, with the agreements that have been signed between the Métis Nation and the federal government is truly historic, and not just in healthcare. So I also do want to reiterate again that it really has been a privilege for me to be part of this journey. And I really have to thank Alexander King for having introduced me to the people in Drummond Sash, notably Carrie Lynn, Renee, and all the other great people that we've had the privilege and honor to work with. And I'll also just kind of echo some of Carrie Lynn's comments. What it really is different in Alberta, we've gone across the country regarding the dry blood spot implementation, but what really was different in Alberta was that public health and working with great people like Carrie Egan, Chris Wood, and the lab folks, Graham Tipples, Kevin Fonseca, and others who I haven't mentioned, we're kind of there almost from the ground, right from ground zero up. So it really is a truly different model, and it's a first among firsts. And the fact that this is also happening in a Métis-specific community, that's also a first as well. So I think this explains why preparing for today and the event and what's about to happen did strike an emotional chord with me. So I'm going to spend a little bit of time on the negative part, but believe me, that's definitely not going to be the focus of my presentation. And by the way, I just want to say is they have really given me a lot of time for this, but I intentionally kept the number of slides and the detail light because I would really hope that we would engage in conversation and dialogue. And like Carrie Lynn said earlier, please, I don't want anybody, nobody wants anybody walking out of this this event kind of knowing, well, what about this aspect of dry blood spots or that aspect. However, so if we're talking about HIV positive individuals who are undiagnosed, we have some work to do. We calculate that about 20%. Now you can argue, is it really 20%, or is it 30%, is it 10%? It doesn't matter. What we can agree with is that it's not zero. About 20% or 1 in 5 of HIV positive individuals out there are not diagnosed, and they may not realize that they're positive for HIV. If you bring hepatitis C into the equation, it's actually worse. It's 40%. In other words, almost half of the people out there who are hepatitis C positive may actually not realize that they're hepatitis C positive, and I'll come back to that phenomenon a little bit later. We also know that these statistics, which have been with us for quite a while, is that the current modus operandi, or the current way that we testing, the one-size-fits all is clearly not working. So whether that's phlebotomy, blood in the tube, or rapid testing, whether it be HIV or hepatitis C, it's not enough. What we need is different tools, and those tools are not necessarily related to different types of testing, but also includes innovation in terms of approaches, partnerships, engagement, etc., etc. Now, I'm stating the obvious. There are reasons why people cannot or will not get tested. Some could actually just be a physical inability to access blood in a tube or rapid testing. However, there's some other social factors, forces, uglier forces, that often come into play. One of them is stigma. I don't think everybody knows what that is. The one word and term that we don't use enough is the R word, and that's racism. And even just being in the prairies for 5 years, I've seen it firsthand. So it's a combination of those forces, physical inaccessibility and the social factors that can play a reason as to why people cannot or will not get tested. And unfortunately, I think our hearts and our minds have somewhat been hardened. And I will even admit, within the government, and if you look at the surveillance surveys, which we have been a part of, is people will think that being Indigenous is a risk factor. Well, in fact, it is not a risk factor. Colonialism is. So that's it for the negativity. And I did need to start with that just so that it kind of sets a tone for the rest of my presentation. In fact, what I want to do is focus on the positive. And this is not about something that we think will happen. This is about something that has already happened and will be happening in the future. And that is simply just increasing access to bloodborne testing through a very, very simple innovation, which in fact, if I was giving this talk in sub-Saharan Africa, you know what, it would be old news. Sub-Saharan Africa has been using dry blood spot testing for pediatric HIV testing for at least 20, 25 years. It's old news there. It's only recently, at least within Canada, where we've asked that question about using that same technology for in a diagnostic capacity. And you'll see soon enough, not just for HIV, and I'll also add, not necessarily just for STBVIs. Now, for those who may not be familiar with dry blood spot testing, I don't know what the word is, I leave you of that concern. If you were born in the 60s, or since the 60s, or have had a child born since then, it's likely that either you or your child have had your infant's heel prick pricked onto that very same card. And every province does it, and what the provinces, well, what public health does is actually test the baby, the infant, for genetic diseases, and if it can be found soon enough, there's things that can be done either through medication or changes in diet and nutrition. So, in fact, that technology and that testing using the exact same cards has been around since the 1960s, and every province pretty well does newborn genetic testing. So today, provinces, in fact, are already experts in dry blood spot testing. It's just recently the application for STBVI testing. Now, this is a little dated, but I think it will still give you a sense of what has been happening across the country. And predominantly, Indigenous-led activities and programs where dry blood spot testing has been incorporated. So I apologize that I actually don't have a legend, but the different colors and the numbers either mean predominantly First Nations communities, tribal councils, health authorities that have either already implemented dry blood spots or are about to, or where we've actually just started talks about implementing dry blood spots. The Saskatchewan and Ontario, Northwest Ontario, have really been quite forward thinking in terms of that implementation, and I'll have a slide speaking to the systems implementation. You'll notice that Quebec is absent from this slide, but some recent talks that we're having right now, that may very well change in the future. And this is just one example where dry blood spot testing has had a positive benefit to the community. And I do, before I forget, I do want to make a comment to the reference of peers. So just in case I forget to say this, I also think as far as the dry blood spot testing intervention is, and because of the ease of collection and the fact that you don't have to be a healthcare worker, it really lends itself well to the decentralization of access to testing. In my opinion, it's peers that are going to be a big part of the solution in terms of decentralizing testing. And the comments that I often hear is, I may have the best relationship with my counselor, but at the end of the day, I'm not going to go party with him or her. I'm going to party with my other peers. Who better to engage that individual than that? And one thing I will say, since I'm on the slide, we've trained, I don't know how many non-healthcare workers. So this includes mental health counselors, addictions counselors, security guards who do needle exchange at 2 o'clock in the morning. Security guards. Well, if somebody has gained the trust of a security guard to exchange their paraphernalia, who better to engage an individual than someone like that? So it goes to show the power of testing, and it really doesn't have to be that complicated. I'm going to spend a bit of time on this slide. This is the test menu of what we can do and what we're about to do, so this gives a little bit of the vision. And I think that this vision and this innovation, and I'm going to talk about the really new innovation in a couple minutes. Our pedigree in dry blood spot testing has not been since we moved to the prairies about 5 years ago. In fact, we do all the viral STI testing for all of PHI's track surveillance studies for the past 20 years. I hate to admit how long I've been with any organization. I think that might date me. So even before we moved up to the prairies, we've tested tens of thousands of these cards. But frankly, it's only when we moved to the prairies, and frankly, actually stepped on a reserve and started to engage with predominantly First Nations initially. Now, STDBIs and HIV are not the only challenges, and HIV even less so. Look, we all recognize that there's other challenges. Housing, mental health, unemployment, water, etc., etc. We can't solve everything, but it didn't take us long to ask the question: what is it that we have that we can share and kind of help maybe make people's lives a little bit better, at least for STDBI testing and linkage to care. And it didn't take long to ask and realize that dry blood spots, at least for the STDBIs, may very well help in that regard. So just to let you know here, HIV and hepatitis C are big ones. As a matter of fact, we probably do more hepatitis C diagnosis positives with some with extremely high viral loads than we do HIV. This summer, we recently validated dry blood spots for syphilis, and I'm stating the obvious here. Every province has either had or is currently dealing with the syphilis outbreak. Now, the one thing I will say in terms of where we're heading as well is later this year, HbA1c or A1c. So for those who are not familiar with that, it's actually a better marker for diagnosis of prediabetes or monitoring diabetes. In fact, that's already been done on dry blood spots. We will not be unique in that regard. Where we might be unique is rolling that out in a true public health fashion. And one thing I did when I engaged and looking into the A1C, I actually very crudely added up the numbers of people who, in Canada, just in Canada, who have diabetes or are about to get diabetes, and it's in the millions. Then I added up the top 5 STDBIs, HIV, Hep C, chlamydia, Neisseria, and syphilis. And it was only in the hundreds of thousands. So just think about it. At some point in the future, we actually might be doing more chronic disease testing with A1C than actual STDBI. So here's the other way of thinking of innovation. We would have liked to have been able to test every STDBI from blood from a dry blood spot card. We know we can't. However, what we do know is that we're able to engage people who would not have been able to engage or won't engage blood in a tube into a rapid testing. So here's the thinking now, is you have the person in front of you, they're engaging the dry blood spots. So you've got the HIV, the Hep C, the syphilis, and the Hep B. You get them to pee in the orange cup. right? You can use the same filter paper and test for chlamydia and Neisseria. Now, is that possible? Well, one thing I will say, see the chlamydia and Neisseria? This is the second presentation of this. Just last week, about a month ago, we had set up a collaboration with other colleagues within the NML to actually ask that question. Can we use dried urine for chlamydia and Neisseria? So I can't remember where I was, but my senior lab manager, Stephanie Lavoie, frankly sent me this thing saying that the chlamydia and the Neisseria, it works like a charm. So think of it now. So you have the client in front of you, you've got the blood, you can do the HIV, you can do all the bloodborne stuff, okay, including syphilis. You can now do the urine to capture the chlamydia and the Neisseria. And think about it, at some point in the future, you can capture A1C. Now, one thing I should also add, can I say this? Creatinine?
What?
Yeah, for kidney disease. Yeah, so having this dialogue through Drum and Sash and interacting with Carrie, we're going to be actually having some conversation, just starting the dialogue with people within Alberta Health Services about measuring creatinine. I can never say that right. And it's really, and that's really to address the kidney disease aspect, right? That's already been done in dried blood spots, clinical chemistry. So going back, think about it. In terms of the innovation, we may be very well be able to capture the big guys in terms of the STBBIs, but also be able to have an impact on chronic disease, notably kidney disease and diabetes. And you might see in the upper right, TB. We know that it will work for IGRA testing or latent TB detection. Not active, but latent. And that can be huge for remote and rural communities. Now, another reason why I have this slide, do you know where this type of innovation and thinking is happening? Let me back up. I'll tell you where it's not happening. Where it is happening is in places like this. And in fact, what's happening today may very well be the first iteration in terms of those new biomarkers, whether it be chlamydia, Neisseria, possibly A1C, possibly creatinine. So, you know what? Let's not just focus on the HIV or the hepatitis C or the syphilis. Let's think about total wellness, whether it's STDI or chronic disease. So in terms of the, we're having a conversation in terms of what are our testing algorithms. So I made this quite simple. The way we do the testing for the dried blood spot is, and I apologize, I thought I had samples here, is we'll just take a part of that dried blood spot and we just do stuff with it. We essentially just add a buffer that's like water, it's got some salts in it. And then the antibodies come off. And then we'll test that for the antibodies to whatever, syphilis or HIV or hepatitis C. If that is reactive, we still have to do another test. And then what we'll do is we'll actually do a test for the genetic material of the virus itself. And then once that happens, it's either positive or negative. In other words, these are methods that are really no different than what's already used for blood in a tube. The only difference is that we've validated dried blood spots as a suitable biospecimen for this, and it works like a charm. Now, the one thing I do want to say is the two provinces, Saskatchewan and Ontario. Canada is the land of pilot interventions. Anybody who's in that research field, and maybe it's the way research is funded in this country, there's no question that we have evidence of great pilots, and then you go for a second round of funding, and you don't get funded. And I'll give one example to the pharmacist application. So Debbie Kelly and Christine Hughes from Alberta, Debbie is from St. John's, they had something called Achieve One, where they were looking at, but employing pharmacists to deliver rapid HIV testing. And they showed efficacy for that. So in Achieve 2, that's where Debbie and I and others, what we were going to do at this point is actually train pharmacists to do dried blood spot collection. So it's not just the HIV, but you can do the dried blood spots. You can capture the confirmatory for HIV. You can do the screen and the confirmatory for hepatitis C, and you can also do syphilis. So, all that to say, where was I heading with this? Yeah, okay. Yeah, Canada is the land of pilot interventions. In the case of dry blood spots, at least with Saskatchewan and Ontario, and possibly with Alberta very soon, how often do you actually get to see something go from pilot to systems implementation? And I'll tell you as an example, just with Saskatchewan, they're already considering, it's very likely that they're going to accept the test result from a dry blood spot to satisfy the case definition for both HIV and hepatitis C. We don't see that in public health a lot, where something goes from pilot to systems implementation. And I got to tell you, this has just happened within the short period of time that we've been in the the prairies. I'm originally from the Maritimes. So, okay, I'm kind of getting to the end here. Now, one thing I will add is when we first started with dry blood spot, and it was predominantly hepatitis C because we were interacting with predominantly Saskatchewan at the time, there was clearly a high-risk component associated with injection drug use. But at least for hepatitis C, the narrative and the way of thinking has to change. And that narrative has changed to, if you were a baby boomer, in other words, born between 45 and actually 75, you should get tested for hepatitis C even just once. And here's why. Or, if you're a baby boomer like me, and I'm seeing this message, well, why the hell should I get tested? You know, I don't do drugs. I didn't go to Woodstock. I didn't go to the Vietnam War, so I know I didn't inject heroin. So why should I get tested? Well, there's two broad categories. One is related to the virus, and one is related to the nature of the healthcare system when you were a baby boomer. So the virus, that virus, hepatitis C, has been around a long time. We actually only started testing for it 1992, 93 in the bloodstream. Number two, it's a tough virus. The same measures that you use to kill HIV don't necessarily kill hepatitis C. So that's why transmission through tattoo equipment, even toothbrushes, shaving blades, etc., that has been documented. Okay? The second part is the nature of the healthcare system. I'm a baby boomer. I do remember getting an injection, and the needle was not plastic. In other words, one use, boom, out it goes into the biohazard. I do remember getting injections with syringes that were made from stainless steel and glass. In other words, they were reused. Now, what could go wrong with that, right? When was the last time you got a public health message that if you received a colonoscopy, right, that you should get tested because the sterilization of that scope, when you're going in for a colonoscopy, you're not getting your own scope, right? They reuse them. And that's in recent times. So the nature of the sterilization back then. So now, here's where the narrative is, okay, I didn't do this high risk, but you know what? I recall getting a blood transfusion for just a routine operation, maybe, while I was growing up. The next slide will actually bring this home. So this is death due to hepatitis C, and it's in the United States. So as of 2012, the number of deaths due to hepatitis C has now surpassed deaths due to all other nationally notifiable diseases together. That includes HIV and TB. Now, here's the second part of this slide. Look at the direction of the deaths. So I guess dotted or slash line. In other words, deaths outside of hepatitis C. See how it's going down? That's due to a reduction of deaths due to HIV, hepatitis C, and pneumococcal. That's what you would expect to see in a modern healthcare system. But it's going up in hepatitis C. Why is that? Likely because of late-stage presentation, cirrhosis, and or worse, hepatocellular carcinoma. And as everyone may or may not know, if you're hepatitis C positive, it will take decades for it to manifest itself, and possibly to, as a matter of fact, there could be somebody or people in this room who are hep C positive right now and don't realize it. So that's why the narrative is changing. And again, we need to change the narrative from just, from just high-risk intravenous drug user to the low risk. You know what? If you're a baby boomer, maybe you should get tested, if any, just once. And this may actually help in terms of addressing the stigma attached to hepatitis C at least, and possibly that may reflect itself to the other STDs. And one thing I will also say as well is that the lessons learned in what is about to happen in the next couple of days, and especially with the Métis Nation, other communities, Indigenous or not, may very well be able to learn from what is about to happen in the next little while. I'm an HIV guy. I'm glad I'm on that side of the STBBI funding world, but I will be the first to admit HIV is not the most important STBBI. So this is Ontario, but this is reflected right across the country. In fact, it's actually hepatitis C. In fact, HIV is not even in the top 5. And this is in terms of the importance, not just deaths, but also impact on quality of life. This is my very last slide. I know it's a little bit busy. What I truly believe is happening, has already happened, and is about to happen with the Métis Nation, is a social change. And there's a business model or a theory known as disruptive innovation. What happens with disruptive innovation? If you just kind of think of discount airlines as an example, quite often they're ignored, disparaged by the status quo. They are simple, they are less costly, and they are good enough. Do they meet an unmet need? Absolutely. The difference about when you have a disruptive innovation in healthcare is that what is different from the business model is that it also addresses a social change. And I do think that that is what is happening across the country as far as dry blood spot testing is concerned. So the only thing that has not satisfied the definition of disruptive innovation is the sustainability and the evaluation, but likely because it's just new, it's just too new right now. But the way I see it, like 5 years from now, with Dan or Rachel, it's your work that's going to be critical to actually address that question. At the end of the day, the dry blood spot testing make a difference. That's what we need right now, is the metrics and the evaluation. Okay. Teammate Rich, merci beaucoup. Thank you for your attention.
Sorry, you were talking about Debbie Martin and her study.
Debbie Kelly.
Sorry, Debbie Kelly, yes, sorry. And that was pertaining to the fact that she wasn't funded the second round, right? When she went forward. Okay, sorry, I just wanted to continue that bit for people. But also, for those who